Now another important session in the wrist is going to start. I am Parag. If we can't diagnose, we can't proceed for the treatment. We all practitioner know that. Let us understand how does what X-ray usually speaks about perilunar dislocation. There is a nice book on diagnostic imaging of the hand, and I have made my talk based on that, reading that. The four important things about carpal dislocations, and which I am going to cover first two, is perilunate and lunate dislocations and perilunate fracture dislocations, and other two we are not going to discuss here. So when we talk about dislocations around the lunate, there are like greater arc injury where the arc starts from either a radial styloid or a scaphoid, then goes through capitate, then goes to the tip of hamate, then goes to the triquetrum. So that is called greater arc injury. And then there are lesser arc injuries. Usually it involves only radial styloid and ulnar styloid fracture. And the mechanism of force that travels between the capitate and lunate. So these are the two important arc that we should try to see on the wrist posterior anterior view X-ray. Then as we understood that when we are dealing with the finger fracture, lateral X-ray of the finger is mandatory. Same goes here. When we are dealing with the wrist fracture, proper wrist posterior anterior view and lateral view is extremely essential to diagnose, not even to diagnose, to miss out any important injury. So these are the standard, position of a patient to keep the hand when we are talking about AP and lateral X-ray. Now, the stability of the wrist is based on alignment and interrelationship of the carpus, and there are three important principles of Gilila that usually we see in posterior anterior view. Number one is arc, second are spaces, and third is parallelism. So we need to see these three things on posterior anterior view of X-ray when we are talking or when we are thinking about managing perilunate dislocations. So what do we mean by arc? So arc means a line drawn from a proximal part of the proximal carpal row. That is one line. Second line is drawn from a distal part of the proximal carpal row, and third line is proximal part of the distal carpal row. If you see any disturbance in this line, that means there is a problem in the carpus. Apart from arcs, so these are the three lines that we see. Then there are spaces. Mostly perilunate dislocation, spaces are not that important, but yes, Terry Thomas sign, like a space between scaphoid and lunate. So each carpal bone has equal millimeter or diameter, equal length of space. So space in between two carpal bone is, we have to understand. And third thing, important thing is parallelism. So usually it is seen in scaphoid and lunate. So if there is a loss of parallelism, then there is a possibility of having injury into the carpus. So these are the three principles of Gilila that we should understand: arcs, spaces, and parallelism. Then what do we see on lateral view? So we have to see the alignment of radius, lunate, and capitate axis, and if possible the third metacarpal in the same length. So this is the distal radius, this is the lunate, and this is the capitate. Usually they are aligned in a straight line. But when we are talking about any lunate pathology, distal radius, then there is a lunate, and then there is a capitate. So lunate is out or capitate is out in the relation. So this is the thing that we should, this is what, now here capitate and radius, they are probably aligned, and lunate is out in the picture, that means it's a lunate dislocation. And when we see a perilunate dislocation, so this is the normal alignment of a carpus in lateral view. So when we talk about perilunate dislocation, there is a distal radius and there is a lunate, and capitate is out. So that is a perilunate dislocation. Here again, what we have to understand is axis between the radius and lunate and capitate. Then I would like to talk about four important case scenarios when we talk about the radiology. We either deal with the perilunate fracture dislocation, perilunate dislocation without fracture, simple lunate dislocations or dislodgement of the proximal row in distal forearm. How do we see that in X-ray? So perilunate dislocation without a fracture, where in a PA view, the triangular shape of the lunate, usually lunate is not in triangular shape. Okay, if we see a triangular shape of the lunate, and if you see that is overlapping with the capitate, that means there is a problem in lunate or perilunate dislocation. Then you have to again see a space between scaphoid and lunate, then loss of parallelism, and disturbs arc of Gilila. So these are the important posterior anterior view X-ray findings. And on the lateral view, we have to see whether the lunate is in alignment with the radius and capitate or not. So this is a perilunate dislocation without fracture. When we think about, or when we want to diagnose a perilunate dislocation with fracture, either we are talking about a distal radius, radial styloid fracture, or a scaphoid fracture and capitate fracture, or a ulnar styloid, where the mechanism of force is transmitted. It's a Mayfield concept, which theoretical discussion I would not like to go, but here what we see is a disturbed arc of Gilila. Okay, and we also see a ulnar styloid fracture. So here the mechanism of force has gone through transscaphoid, capitolunate, then perilunate, and then through the ulnar styloid. So this is how the mechanism of force has been traveled. So this is distal radius, lunate, and this is the capitate. So this is a perilunate dislocation. Now another important case, sometimes you don't see a fracture in the scaphoid, but you see a fracture in the distal radius. This is a lesser arc injury, where there is a transradial styloid fracture, and you see a disturbed arc of Gilila, where the scaphoid, capitate, and ulnar styloid is intact. Okay. Now the last case scenario we usually see is dislodgement of proximal row in the distal forearm. This is extremely high velocity trauma. Usually they may have associated injuries, and on X-ray we sometimes see, we either label them up loose pieces of bone. They usually have, sometimes if they are conscious and well oriented, they may land up with the carpal tunnel syndrome. They may have symptoms of carpal tunnel syndrome. So don't miss out these X-rays also. So to conclude, on PA view of the wrist, arcs, spaces, and parallelism that we have to watch, fractures in the radial or ulnar styloid, scaphoid, and capitate, and on lateral view, spill teacup sign, axial alignment of radius, lunate, and capitate, as well as third metacarpal has to be seen, and take full length of forearm X-ray to rule out proximal fractures or dislodgement of carpus. Thank you so much.